I'll clarify what exactly this title means in a bit on the slides. But just to give you some background, so actually we collected the data some time ago, and I've also analyzed it some time ago, but really just need to write it. And I wanted to do that also here in Manchester and just like kind of write it up. So I'd also especially be welcoming any ideas on like how to sort of package this paper nicely for, yeah, we're thinking about pharmacoeconomics. So with that, I'll start. Just to note, this paper is together with my supervisors, Esther de Becker-Goop, Tom van Oorti, and Jorien Veldwijk, all from the Erasmus University. Okay, of course. Now, there we go. So let's briefly start off why we measure patient preferences. So if we think about the medical product life cycle from drug discovery to what ends up being prescribed or on the market, there's a lot of decisions being made at different time points. And you can also think about these kind of decisions and, okay, do we go for a drug that is more effective but has more side effects? Or do we go for a daily pill or a weekly injection? But of course, developing all these additional options takes time, money, and evidence. So that's why like what ends up being on the market is somewhat limited if you think about what would all be possible to develop. And recently there's been a much more, a push to integrate patient preferences throughout this medical product life cycle at different stages, so that you would still develop clinically effective treatments, but also look at that they're aligned with what matters to patients. And the idea is that that will improve patient satisfaction, reduce unmet medical needs, increase medication adherence, and thereby potentially improve cost effectiveness of drugs, and also just sort of help planning and prevent trial and error implementation. But how do we measure these patient preferences? So the most commonly used technique are discrete choice experiments, and I will refer to them as DCEs from now on. And this method became so popular because it is pretty good at measuring trade-offs, because often the perfect drug or medicine doesn't exist. It involves quite a bunch of trade-offs. So think about how much symptom improvement is worth the risk of side effects, or would patients prefer more convenience even if the drug is less effective? And DCEs can measure and capture such trade-offs through presenting repeated choice tasks to patients and sort of inferring their preferences from these different choices. And below you see what such a choice task would look like for using the flu vaccine as an example. And there's two words I want you to memorize for this presentation, and I'll quickly say something about them. So one is, on the left side, you see effectiveness, risk of mild side effects, severe side effects, protection duration, incubation time. So these are like the general characteristics of a treatment, and they're called attributes in the DCE language. And what is important to note is that these attributes don't change throughout the choice task. They tend to be the same set of attributes that characterize the treatment options. On the other hand, the values that you see inside the different options is what is being called the levels or attribute levels. And that's what actually changes throughout these different choice tasks that are repeatedly asked for patients or respondents to choose between. And basically, by having people repeatedly choose between options, you can also compute market shares. And that can be nice to anticipate what would happen if you would introduce different options to the market, and you basically say, hey, if this and this would be what patients can choose from, this amount of patients would choose this, and this amount of patients would choose no vaccine, for example. But of course, you might already see the problem of hypotheticality, because in the end, we'll always record hypothetical choices, which is needed in health mostly because you can't just throw a bunch of things on the market and see what happens. So the main thing to do is that we need to align the DCE scenario as closely with the real-life choice scenario to be able to anticipate these market shares as accurately as possible. So diving into more the topic of this specific presentation, this is where this taps in, because this is easier said than done. And especially when we look at side effects, this can become quite complicated. On the left, you see a patient information leaflet example for a flu vaccine. And well, you all might know that flu vaccine is also not the riskiest treatment with like super many side effects. But here already you see like quite a long list. And if you would take each individual side effect and put it in as a attribute, we would end up with way too many attributes and cognitively overload anyone trying to fill in these choice tasks. So we need to group them or categorize them to keep this cognitive load manageable. But that, of course, raises the follow-up question, how should we group them? And then how should we label these groups? And basically, there's two prominent options. So one is that you do it based on severity, and that is actually what you see in most DCEs. So you would have like mild, moderate, or severe side effects as different categories and attributes, and then have like a frequency, how often they occur. However, if we look at the package leaflets, we actually see different categorization, and that is based on the rate of occurrence, which ranges from very common to very rare. And well, there's like fixed categories by the European Medicines Agency that have like fixed ranges that correspond to each label. I actually looked it up, and it seems to be the same in the UK. In a lot of cases, this, depending on which option you choose, will only affect the labels, because you have a lot of mild side effects that are very common or common, and a lot of severe side effects that are very, very rare or rare. But of course, it is not necessarily the case. That's why in this study, we for now focus on the effect of the changing the label only. So if we put this into practice, we see that taking the flu vaccine as an example again, we have a bunch of side effects, and this is just from a previous DCE, which we kind of read it. We have a bunch of side effects that were labeled as mild, but they're also very common. And we have a few side effects that are very severe and that were also very rare. So what we did is we basically took these two approaches and did a DCE in which we randomized people to receive exactly the same DCE, only changing these category labels. And in both conditions, like all the attributes and the side effects were explained identically before the DCE. People anytime during the DCE could use a hover function to reread the side effects. So if they would hover their mouse over the risk of side effects, we explained that also they would see a list of what is included in there. And also we visualized the risks using icon arrays identically in both conditions. So only the labels which I highlighted below in bold was what differed between these two conditions. And I'll call them for now on like the severity labels condition and the occurrence label condition. So the follow-up question is, does it alter respondents' risk perception and impact their preferences and therefore the DCE results? So it doesn't matter which categorization we use. And there's a few from Rachel just mentioned, I have a background in behavioral science, so there's a few behavioral theories that would suggest that this might be the case. I'll quickly walk you through them. So one is priming. And priming basically means how exposure to a stimulus may subsequently influence a subsequent decision. So you might argue that priming happens in both cases because, well, either you prime on severity or on the rate of occurrence. However, if you remember what I said in the beginning about the attributes and the levels, the severity basically stays constant across the choice task. The side effects itself, they don't change. On the other hand, for the occurrence rate, this differs between the choice tasks. So if I go back, you see like these levels of 20 or, oh, now here it's 20 everywhere, but anyways, it could also be 10 or 50. They differ between throughout the choice tasks. So technically, this occurrence rate label is somewhat uninformative because the actual occurrence rate is captured in the attribute levels that change throughout the choice task. So that might suggest that the severity labels may lead to a persistent priming effect, while the occurrence rate labels may balance out this priming effect of the occurrence rate. And what I visualize below is a bit for the DCE people, but there's like a measure in DCEs that is called the maximum acceptable risk, and basically that captures how risk-taking people are and how much of an increase in a risk there of side effects they are willing to accept for an increase in effectiveness. And you would basically expect that if this priming occurs, you would have like that they're like more risk-taking for mild side effects and less risk-taking for severe side effects compared to the very common and very rare side effects. So you would see a priming that sort of accelerates the preferences in both directions. The second behavioral implication relates to the evaluation strategy. So how the information is processed and subsequently evaluated. And well, I call this category-based evaluation versus subjective aggregation. So please don't Google this. I kind of made this up because I couldn't find anything that exists that describes this. So basically, for the category-based evaluation, you have a lot of side effects that are summarized under one label of severity, so mild or severe. So that technically offers like what we call a mental shortcut. So it permits people to not actually engage with all the listed side effects, but just only rely on this category label, mild or severe, and make choices based on that label without engaging in this with the individual side effects categorized under that label. While for the subjective aggregation, we basically don't have the severity label. So we have this occurrence rate label that is not really that informative. So we might push or force people to evaluate the severity of each side effect and then sort of mentally aggregate them and make choices based on that. So if that is the case, two things might happen in the data. And one is we might see more preference heterogeneity for these occurrence rate labels, because there's just simply more subjectivity involved in that process of judging how severe you find these side effects, which might drive variation in the preferences. On the other hand, what I just described is also a bit of a more complex process. So in the other one, you have this mental shortcut and makes it easier to maybe make a choice. So the reliability and the consistency of the choices might be lower when using these occurrence rate labels. I'll let this sink in for a second. So basically, to give you a brief overview on the research design, is we got ethics approval, we pre-registered the study. For these E people, we did a Bayesian efficient design with a pilot, an engine, and had 48 choice tests distributed over 4 blocks. But that means that basically each respondent got 15 choice tasks because we included a few manual choice tasks that would check the reliability and validity. So each respondent completed 15 of these choice tasks. Programmed and hosted this in the Sawtooth and recruited participants via the data that are 60 plus in the Netherlands. And basically this was because these are the people that are being invited to receive the flu vaccine yearly in the Netherlands via their GP. And these were randomized to receive like either the severity or the occurrence rate labels, and we had around 550 people per study arm. So let me jump to the results. The first hypothesis, basically, we do see somewhat is in line with what we hypothesized. So we see that people are somewhat more risk-taking when we use these mild when a side effect is labeled as mild as opposed to very common, and we see that people become much less risk-taking if a side effect is labeled as severe as opposed to very rare. So that is supportive of this priming hypothesis that I mentioned earlier. For the second hypothesis, we looked at preference heterogeneity, and basically for mild side effects, this was in the same direction. So like there was more preference heterogeneity for the very common side effects than for the mild side effects. But for the severe side effects, this was the other way around. I just want to notice, like, if you look on the y-axis, mean-adjusted standard deviations from a mixed logit. But basically, what I want to point out here is that it is quite small. So that's also why I put it in brackets, because it's not really gigantic differences. And with regards to the complexity, so reliability and choice consistency, we didn't find any significant differences. So with reliability, basically what you can do in a DC is that you just give people exactly the same choice task twice, for example, the third choice task and the 14th choice task, and see if they give exactly the same response. And here you see how many people gave exactly the same response. And then we also looked at choice consistency, which is basically you can look at the scale coefficient, and if that is significant for the study arm, that would mean that maybe choice consistency differs between the study arms, but also that was not the case here. So finally, what I want to show to you is that after the choice task, we gave people all the side effects that were included in the DCE, and we asked them, which one do you actually think are mild, and which one do you think are severe? And we see quite some discordance here between what clinicians classified as mild in the first DCE versus what patients actually think is mild. Especially when you look at fever, there's only 30% that think it's mild, and actually more than 30% think it is severe side effect, which maybe given the population of 60 plus people might not be too far off that they can find something like this, yeah, quite severe. So to sum up, these European Medicines Agency occurrence labels that are currently also being used in the UK are often more in line with real-life risk communication to patients because they're being used on the leaflets. And from what I understood is that these mild or severe categories are sometimes used, but not really when communicating directly to patients. So the occurrence labels align more with real-life risk communication. Second is what I just showed to you, is that respondent severity perceptions may not fully align with those of researchers or clinicians, so there might be some discordance if they rely on these labels. And well, the results did seem to suggest that severity labels may prime respondents and artificially deflate or inflate their risk preferences depending on the type of severity, while occurrence labels might to a little bit increase the preference heterogeneity, which was for mild side effects, which somewhat makes sense because that was where the most discordance was between whether they perceive it as mild or not. So yeah, that was also like what it was associated with the most variation. And there seems to be no difference in complexity in terms of the reliability and the choice consistency of the results. So what I want to highlight here is that only changing the label of these side effect categories already alters the risk preference estimates. And implications for health preference research would be that mislabeling or just labeling side effects categories may alter risk preference estimates. So it's important to be aware of that. And especially now we only change the label, but clinical application areas where, like, depending on which label you go for, might affect how the side effects are ultimately categorized, may increase this discrepancy between using severity versus occurrence rate labeled. But of course, future research is needed to look at that. And finally, if a DCE is aimed at predicting uptake, it may be especially important to use these occurrence-based labels because it's more aligned with real-life risk communication. But of course, that may depend on the region because this is how it's being done in the EU and the UK, and it might not apply to any other country. So thank you for your attention, and I'm curious to hear your questions.
Great, thank you, Stella. Great presentation, nice and clear. I can't see any questions in the chat. Is any? Oh, I can see. I thought so. Chris has got his hand up. Chris, do you just want to introduce yourself to Stella? She
yeah.
Sure she knows of you, but she may not know you.
Okay, hi. So I'm a professor in health economics at Leeds. I've been in health economics for, God, nearly 30 years now. I actually did my PhD in Groningen, so ik kan een klein beetje Nederlands praten. Well, it's faded a little bit.
Well, I'm also not Dutch, so please
no,
not.
you're from Germany, yes, but which I guess is even weirder, isn't it? Because whenever I used to speak in Holland, even if I tried in Dutch, it'd immediately answer in English. I think it was only in my third year that I started getting responses back in Dutch, but never mind. I'm also an econometrician as well, and I think that's what's motivating this question, I think, if I may. So in your discrete choice, you've got the three options, is that right? You've got option A, option B, and basically a null option.
Yeah.
I'm always curious as to how those things get incorporated in the econometrics, and I have a worry, and I'll outline the worry first, in that these things are about expressing preferences, and sometimes I wonder whether by putting a null option in, you distort the data somewhat. So, for example, my silly example is option A, I stand on your foot. Option B, I chop off your arm. Option C, neither of those. Now, I'm guessing that you wouldn't find A nor B particularly palatable. It would not like either of them, so we'd go for C. But I'd also challenge the notion that you wouldn't have a preference between them. I'm sure everybody here would rather I just stepped on their foot that went crazy and chopped off their arm. So I worry that sometimes the null option is treated as not able to express a preference or indifferent between them. And I think with my silly example, it shows you there's a real danger in that automatic interpretation of the null.
Yeah. A very interesting question. So it's interesting because actually I'm also teaching a DCE course for master students, and I really often see this, the first draft of their DCE has a neither option, and we very strongly, like, we say, okay, never do that, because indeed, like, it's unclear. So the neither needs to be either a status quo or a like no treatment. And then it is quite important to also like explain or specify what that means. And well, I think in this case, we're always trying to, in the beginning, explain, hey, okay, we have these sort of educational materials, we call them, where we explain them what all the attributes mean. And ideally, also the implications of choosing this no option. But I definitely think that in a lot of DCEs, and probably also in ours, like improving the clarity of what the implications are of choosing the no option should be more pronounced.
So sorry, how does it actually fit into your econometric specification? Because if there wasn't the C, I guess it's just a conditional logit model. How do you kind of wire the C option into that?
Well, there's different possibilities to doing that, but actually what we mostly do is that we have an alternative specific constant that captures the no option. And that is then sort of like the coefficient of that alternative specific constant is then relative to the base case option of like all the other attributes.
Okay, thank you.
Yeah, you're welcome.
Thanks, Chris. I've got a question from Catherine and then Maria.
Hi, it's Catherine. I'm Professor of Health Economics at the University of Manchester, and Stella's come here to visit me. Just an observation about Chris's question. I think people who do discrete choice experiments do not pay close enough attention to this, let's call it the third option. And so I think I always try, and when I'm thinking about the attributes that are specified in the design, try and make sure that I'm very clear how the levels refer to that no option or neither option. But I would say as well, in your example, Chris, maybe think of this, that we also, I don't think people are very clear in the literature about distinguishing between generic and labelled alternatives. So what I mean by, so you gave an example of a labelled alternative, step on my foot or well, chop off my hand, that's labelled. If you were to say injury A or injury B, that's generic. And the way that we interpret the no option is different, or should be different in our design. So anyway, but that's a very boring point. I can see Rachel raising her eyes. Can I ask my question? So my question or observation is, so you've generated two types of side effects. So labelled in terms of their occurrence and severity. But when I looked at the examples you gave, I actually think there are three types. So you have labelled them as symptoms, so things like fever, skin irritation. But then the severity bit was more labelled around the consequences of what happens about those side effects. So they were labelled in terms of hospitalisation or... so I think, unfortunately, you've kind of conflated two things there. So there's the consequence of having the side effect symptom, and there's the actual symptom that you experience. So you might have problems with your gallbladder. That's a symptom, but the consequence of that is you have to have your gallbladder removed. And so I think maybe when you write this up, you might need to think about being clear what you mean about severity.
Yeah.
And I know there's a lot more there might be some more pharmacists on the call. I spot a few pharmacists on the call, so they might chip in.
And that's a very interesting observation, because that was also one of the first things I brought up for discussion when we were about to run the study, because this was based on a previous study that was quite large, and it was basically designed together with clinicians and patients some years ago. But I had the same observation where I was a bit, okay, well, hospitalization and permanent damage, that's quite broad. But it was basically, they told me they had put in a lot of thought into it when previously designing it, because there's so many things that can apparently happen and that are then like very technical and difficult to explain to patients, so that the kind of like summarizing it as its consequences was perceived as the best option. So I just went with the safe option of saying like, hey, we're just sticking to how they did it beforehand, to get my head out of the, I don't know how you call it. But I totally agree, and I found this also like something to think about.
Great, thank you. I wasn't raising my eyes. I was looking up at the other screen. I'm just doing it again to demonstrate that I wasn't doing that. Catherine knows I have very complex views about DCE due to my experience associated with them. Anyway, so I'm going to hand you over to Maria, who's got a question.
Hi, Stella. I'm Maria. I'm a research fellow at MJ. A question about your choice tasks. You said each individual was given 15 choice tasks. Is that correct?
Yeah.
it can seem a little burdensome on the responder to deal with 15 choice tasks. So I was wondering, well, one was why you chose 15, and the second was, did you do any additional analysis to strengthen your validation? Like, did you look at satisficing or noise in the data? For instance, later responses may be less reliable. Were they answering a bit faster, perhaps?
Yeah. Thanks a lot for the comment. So indeed, the 15 choice tasks is basically, we needed 12. So there's a bit this formula for ensuring that you, because some of the models that I presented are like mixed loaded models that are based on individual level preferences. And basically, to be able to estimate these individual level preferences, you need a certain number of observations per person. And that was, in this case, it has to do with how many attributes and levels you have. And in this case, that was 12. But indeed, we wanted to check for the reliability and validity. So that is why we added 3 extra choice tasks that, one of which one was repeated. And then like one was having a clearly better option. And the third one was sort of transitivity check. And so we added these to check that. And with regards to sort of the heuristics, so actually satisfying is quite difficult to model, but there are a bunch of other heuristics that you can model in the DCE. So that could be interesting to look at in general, because, well, there's evidence that they're sometimes present. So I don't know if you have any specific ones that you would expect to differ between the 2 study arms. And with regards to the response time, if it gets quicker to the end, I find that a bit of a difficult one, because also people might sort of form their preferences throughout the choice task or get used to the format. So they might become a bit quicker in making these choices just from as sort of learning effect. So I find it difficult to make any strong judgments based on the completion time towards the end of the choice task.
Thank you. Can I just ask a follow-up?
Yeah, please.
On the
Go ahead.
first part, you said you added extra tasks, etc. I'm just wondering, out of curiosity, how did you deal with this data? What did you find?
So the repeated choice task, and that was early, and I think was like 85%, between 80 and 85% that made the same choice twice. I think it was, I don't know, I guess the 4th choice task and the 14th or something like this. That was the same, you would see if they make the same choice. And then there was one choice task where there was a clearly superior option in terms of the effectiveness and risk of side effects. And the other ones would be the same, so the waiting time. And I think on top of my head, 95% chose that clearly superior option or opted out. I mean, that's also fine.
Okay.
And then the other one was basically this transitivity combined with, like, they call it a cross-set monotonicity. So it's like a bit transitivity combined with this clearly superior choice task. And I think there it slightly dropped to like, I don't know, on top of my head, like 85, 90% passing that test. So we were pretty happy with the data quality, actually.
All right. Thank you very much.
You're welcome.
Sorry, I was on mute there. Before I go back to Catherine, we've just had a little conversation here about the fact that only 82% of the cohort thought that death was a serious outcome. So I just wondered about the other 18% of people who thought that death wasn't serious, what you did with those respondents.
Or mild.
Yeah, and then so the 5 thought that death was mild. So you had that sort of, that little bit of an interesting response, what you did with those responses.
Well, I just went back to the slides. It is at least 88, so that makes it a little bit better. But it is still 12%. Indeed, I was also surprised by that. But we discussed it and we thought, okay, actually, there might be this thing where we just ask them basically, which side effects do you think are mild? And then you could check all of the ones you find mild. And then we would ask, which ones do you think are severe? And then you could check all of them. And then I think there might be this thing where people are like, okay, this is not even severe, this is horrible, or something like this, where basically severe is not bad enough for them to check it. That was our idea of what might have caused this.
Right, but surely if somebody thinks death is mild or not severe, surely that means they don't understand the question or they've not read it.
Yeah, I mean, like the classifying death as mild, that was by 0.3% of the people. So I guess these are just literally, I think they didn't read it. But actually, like all the other people, they just didn't classify it. Neither as mild nor as severe.
Right. Okay.
Because we didn't force them to classify it. So I think they just sort of say like, okay, it's neither mild nor severe. It is, doesn't fit in any of these categories, I would assume.
Okay. I'll hand you over to Catherine now.
Yeah.
People never behave how you want them to in choice experiments, do they? So I was interested because we've got a lot of people here that are also, so this is a health economics and safety network. So there's people perhaps more familiar with dealing with harms or side effects in an evaluation context. And I think there are similar challenges with including side effects in economic models in the same way as there are about including side effects in preference studies. But what I don't see are those two communities talking to each other and learning from each other. And I think that's disappointing, really. So I'm just thinking about this, going back to this severity thing about symptom versus consequence, and whether you had looked at any economic evaluations, maybe around flu vaccine to keep it manageable, to see how they had dealt with the side effects in any economic models and how they had categorized them and presented them within the modeling context. Had you had a look at that?
No, I actually didn't, but I really like your point because I think that this would be very important to look at also maybe in the project we're talking about, because ideally a lot of DCEs also want to like sort of help or support HTA or sort of like go together in making informed decisions. And I think that highlights the importance of these two being aligned, because if you have a very different categorization, it can affect the result and then they're like less aligned. So I really, really like your point and think that that could be really cool to take a look at, and also like in general to consider when planning a DCE that is applied and should go together with HTA.
I'm going to hand you over to Bowen, who's got a question.
Hi, Stella. Nice to see you. I'm a first-year PhD student in MCHE, and I'm working on analyzing the economic burden of the prescription opioid use. So I also needed to see a lot of article about the side effect and adverse event. Interesting things I find is that you can classify the different adverse events into the different severity. Like the fracture is very serious adverse event, but the headache is maybe not such severe. But even for the same adverse event, it have the different severity. Like we can have a very serious headache and I need to go to the hospital, but maybe some headache I just need to rest for 10 minutes, it will recover. I would like to know how you handle this problem in your study.
Yeah, I fully agree. So I think ideally the severity of the side effect should be described once you describe the attributes. But then I think you run into this follow-up problem where like maybe the objectively same headache might be experienced as very severe, or subjectively be experienced as very severe, versus very tough. So I think that is like quite a tough one. So in this study, we thought, okay, we'll just go to like aligning. Our main point was like, hey, okay, these side effects are being communicated differently on these package leaflets versus in the DCE. If we make claims on our DCE results being externally valid, we should align it, right? If it doesn't make a difference, well, then you're free to do whatever you want. If it does, well, maybe go for the align it with real life communication. And then, well, headaches or something like this are also often not described in terms of their severity there, which I think is a limitation. And yeah, I think probably everywhere, but I can also see why that's being done, because it's like very, very difficult to like to say something about that, I assume, because there's probably also a lot of individual variation for how long it lasts and how severe it is, and then also like how severe it is being not how intense it's being perceived by the patient experiencing that.
Yeah, because when we put in economic models, when we build economic models of harm, then we very much focus on the severity of the harm and how long it lasts. So it is, if it was a headache, we would do what Bowen has described and look at what that actually means in terms of, you know, because we're interested in what's the quali decrement, and in terms of, you know, how long have they got the headache and how serious is the headache, and then, you know, if they are admitted, you know, what are the resources, you know. So for us, it is very much about what Catherine was talking about. It's the actual experience of the adverse event. And that was one of the things that, sorry, Bowen, if you've got a follow-up question on that.
Yeah, no. Thank you so much for your answer.
I can't see anybody else that's got their hand up at the moment. John Silcock, where are you? I can only see his JS. Hello.
I'm here now. Can you hear me all right?
We can hear you.
Excellent.
From the wrong side of the Pennines.
I know. I'm a pharmacist, Stella, and I've got some health economics training, but the maths now escapes me, if I'm honest, despite the proximity to Mandy Ryan that I had in my early years. So I'm just wondering about the practical consequences, because it is quite complex, I think, as Rachel's outlined. Risk and severity don't necessarily run with each other, but usually they do. Usually the common things aren't severe and the less common things are, but that's not always the case. And then there are the consequences, you know, which could be bad either way. And also, although it's a discrete choice experiment, in reality, people are expressing their preferences, but they'll take a medicine and then things happen, don't they? It's not like a sort of a consumer product or anything. Actually, what happens to you is, you know, completely unpredictable. So I'm just wondering, my question is, I suppose, if the effects of the changing the wording are small, which I think you're kind of suggesting, but I might be wrong, are those relatively small effects from changing the wording dwarfed by the complexities of the real life situation? You know, because in real life, you know, what these medicines do to any one individual is pretty unpredictable at the individual level, you know, so my question therefore is, like, does it matter in the real world, I suppose, and if the effects are relatively small? Yeah.
Okay, I think there were like a lot of different sub questions in there. I'm going to try to tackle them. What was the first one? I didn't write it down properly.
That reflects my stupidity more than anything else.
No, not at all. But I know you made another. Oh yeah, no, I got it again, because you made another point that I found really interesting. Yeah, so basically that's something I also thought about, because of course we just used the flu vaccine as an example, and there we have a bit the comfort of it is like sort of a yearly choice that you make, and then after that you'll have side effects or not, and they might be mild or severe or whatever. But of course, if it's about other medications that you might keep on taking, you might be like, hey, okay, there's a bunch of mild side effects, let's see if I get them or not, and then discontinue. So that might not be, you might not need to anticipate them to the same extent as if it's compared to when it's a one-time treatment or like a yearly or screening or whatever that is like, and has a longer time frame. So I do agree that there's a difference that is maybe not enough reflected on current DCEs. The second one was, so basically this difference was quite small in terms of the heterogeneity in these results, but actually when it came to the risk preference for the severe side effects, that was a very large effect. And so there, it was quite different. It really changed trade-offs that people made. And what it means for real life is I read a few articles that were published, I think like more than 20 years ago, where like when EMA introduced these categories, and they were from a health psychologist or something that was really strongly advocating against using these occurrence rate labels, because basically she communicated to patients, hey, these side effects are very common, these are uncommon, and basically but without any frequency, and then ask patients to say which frequency they associate with these verbal labels. And that was completely off. So whatever patients attached to just reading these, whatever is very common and common, was like not at all aligned with what currently, policy or pharmacy policymakers have as categories with the verbal label and the frequency categories. And I think in terms of implications for real life, there might be something to it, because we know that there's a large, or like not large, but there is a considerable amount or subgroup of the population that have troubles with numbers, and especially these sort of frequencies that might like sort of ignore them and stick to the verbal label, and then will have a misperception based on if it's communicated like that to them. And GPs might also use that language where they just say, hey, these are common side effects, or these are very rare side effects, and not tell them the occurrence rate intervals. So I think that there might be some real life implications. Does that answer your question? Okay.
Thanks, John. We've got time for one more question from Maria.
Sorry for being a bit greedy here with my question. About your risk. So you have your risk perception is an observed attribute. I was wondering if you thought about modeling it as a latent variable, just because what participants see or what they're presented with versus what they perceive could differ. And if you perhaps looked at latent class analysis, perhaps you'd be able to capture individual differences in interpreting the same observed risk.
Yeah, that's a good one. We did choose for a mixed logit because we had this one hypothesis relating to the preference heterogeneity, and the mixed logit is quite nice to quantify that because it gives you the standard deviation alongside and estimates that. But to dissect that in a latent class, well, I actually had a professor suggesting to me to do a latent class with mixed logit classes as latent classes, but I'm not sure if my data will sort of enabled me to do that. I'm not that optimistic about it, but yeah, it's an interesting idea to do it in latent classes and look if there's specific classes, and then maybe also like look at class membership predictors of these classes to see if there's specific subgroups that are most affected in terms of like the difference in their preferences.
Okay, thank you.
Thanks, Maria. Unfortunately, we've come nearly to the end of our hour. So I'd just like to thank Stella for a really stimulating presentation, and also say thank you to everybody who's asked some really good questions. It's been a really interesting session. Thank you very much, and I hope you have a good afternoon, and hopefully see some of you back for the 23rd of September for our next seminar. Thanks again, Stella.
Thanks. I'll just put my email address in the chat if there's any further comments or thoughts.
Yeah, absolutely. If anybody wants to pass on some comments to Stella, then yeah, there's her email in the chat. So great. Thanks very much. Thanks, everyone. Really nice to see you all. And I hope you all manage to get some sunshine over the next couple of days.